questions that we got, which were posed on the group, and we had over 200, which we have cut down, I promise, were to do with testing and the treatment protocol itself, and obviously side effects. So in your view, why is the NHS getting this so wrong? Why are they getting testing so wrong? What's prompting this?
Well, this has been the policy for 70 years.
Mm.
So it's a bit like creosote, that, you know, it just seeps through the system and gets into the system. A bit like creosote on your fence, and your devil's own job getting it out once it's in there. Mm. The difficulty is that when Cass did his original work, the scientific methods weren't as developed and as sophisticated as they might be nowadays. But in other words, and if you read Cass very carefully, he was a really excellent clinical scientist. He was microbiologist clinical. He never made the claims that people were making, never. And he was more interested in the midstream urine sample as a means of culturing the urine, and he was just interested in the problem. How do you decide that the bug you're growing definitely comes from the bladder? That was all. Now, we think, looking at it, as he tumbled on something. I've got a lot of insight into this by supervising Jane Curry's PhD. She's done her PhD on urine infection in pregnant women. Mm. And Cass did his fundamental study in pregnant women. And what he did was took a whole lot of pregnant women, and he did urine cultures on them. And those that were positive, he split into two groups. And one group he treated with antibiotics for the whole of the pregnancy, and the other group he didn't. And the incidence of miscarriage, pyelonephritis, preeclampsia, etc., was much lower in the other group. It was a seminal experiment. And from that day onwards, people said, okay, fine, right, we'll diagnose urine infection based on the Cass criteria. And no one did the necessary work to test this. Now, what we think now is that the thing is that if you attempt to repeat Cass's work nowadays, it doesn't turn out like that. There's no difference between the two groups. And what we think is that in those days, Cass was in fact identifying the worst affected. Now, certainly when we were doing the cluster analysis with my friend, colleague, Professor Maria Diorio, who's the professor of mathematics statistics at UCL, she identified the fact that the urine cultures were positive in the worst affected patients. Mm. And we also noted that pyuria, high pyuria, is quite predictive of a positive culture. Mm-hmm. And so we think that when the culture's positive, it can imply that the patient's got a pretty significant infection going on. Now, this is where you mustn't fall into the trap, which so many people do. Okay, if that's the case, then the bug we culture is the cause of it. No. If all you lot will have experienced shedding. Mm. So when you've got an acute urine infection, you are shedding, it's snowing. Yeah. And all that accumulates at the base of the bladder. Yeah. In this sort of deposit that consists of shed cells, dead white cells, fibrin, blood, and so on, that all starts rotting down. And there's an enormous amount of carbohydrate in that lot, along with essential nutrients. So it's a beautiful culture media for bugs. So we must expect that there will be all sorts of bugs that will be feeding on that debris. And it's quite likely that they're behaving a bit like those fish that clean the gills of big fish. What are they called? I've forgotten that oh, it doesn't matter. That those bugs are there are cleaning up your bladder for you. All right. Now, if they're thriving and they're having a great time doing that, well, God bless them. But there's so many of them, they're likely to grow up on the culture.
Yes.
And so you've got to be very careful, because what you isolate from the culture might well be your friends. And the fact that the cultures tend to be more positive with more severe disease may be just a reflection they're more debris, and so the saprophytes are having a good time of it. We don't know, so you've got to be ever so careful. But we think that those women that Cass studied were particularly badly affected. And in other words, he was studying an enriched sample. And in any case, that people should never have used his data to extrapolate the way they do, because, you know, most of the patients we're seeing are not pregnant. And I can tell you from looking after pregnant women, the pregnant women behave very differently to the rest. So, but this became the accepted wisdom. And the other thing is that if the culture is positive and the person's got more severe disease, then it leaves a greater impression with you. And you've got this, you end up with this recall bias. So you tend to recall the worst affected people, and they have positive cultures. So it just emphasizes the fact that the positive culture implies disease, and so on and so forth. And so the idea that we define urine infection by the Cass criteria is there, it's tattooed into the soul of medicine. And it's going to take a heck of an effort to jemmy it out. And you've got an enormous bureaucracy that's supporting that. And you've got a whole infrastructure supporting it, with all the sort of midstream urine specimen systems, the robots in the laboratory processing them, all the guidelines and so on. So if some sniveling little git comes along and says, look, I think it's all wrong, all right, it's going to go down like a lead balloon. I mean, it's just not popular at all. And what we found, and what others have found, is just the culture is providing us with desperately bad information. And unfortunately, everything is calibrated to that culture. So my view is, what I developed at the time is just to keep stating the science, just bore everyone silly like a gramophone with the needle stuck, just keep on repeating the science until it gets through. And I think that's the only way of shifting it. But I think that in this day and age, the voice of the patient's making a great difference. All right, that is the most transformative thing. And I think that, you know, that with the improvement in communications with the internet and the original influence of things like the patient association, and particularly politicians are coming around to the fact that these health services are for the patients, all right? And if the patients are not happy, then there's something not right.
What happens then if QT is left untreated? Can it just clear up on its own?
We suspect that it can, and I'm aware of. I'm certainly aware of some patients who just got better, and I'm amazed, absolutely amazed. And I'll tell you an interesting story that years and years ago, I was dealing with this woman who had terrible urethral pain. And it was when I was at St Pancras Hospital working with Jenny, and long before I went to the Whittington, we couldn't get this sorted. And I was trying everything that I could think of. And she, for some reason, she and her family moved away. But about 4 years later, I got a letter from her saying, I just thought I'd write to you because I've suddenly been rendered better. And it was nitrofurantoin that did it. I had a course of nitrofurantoin and then I was better. And I was staggered because we tried nitrofurantoin with her because we suspected a urine infection, even though we couldn't see that there was anything. She got exposed to some course and they did it. I think it was less than 4 years later. So you do get these inexplicable recoveries, but certainly, as you will probably recognize, that there's a hardcore of individuals who just suffer relentlessly. And that spontaneous cure does not appear to be materializing.
Yeah, absolutely. Why you don't use microgen results, but we might have had an answer to that in your explanation of
well, there again, it's a very difficult concept for people to grasp, but it hinges on the wonderful problem of causation. If you go and isolate a bug, how can you say that it's causing the infection? Now, the microgen tests, we use equivalents all the time, and they're simply a genetic screening of the microbiome, and you'll get almost identical results in the normal controls as in the patients. And there's a Venn diagram in the book that shows the 90% overlap between those groups. So that immediately alerts you to the fact, hey ho, what's being isolated here doesn't necessarily say that it's causation.
Yeah.
Now, in fact, causation's been a monumental problem for years and years and years, but it's been cracked by this wonderful man called Judea Pearl, who is a professor in California and works on artificial intelligence and machine learning. And it's very complex, but he cracked the problem of probability and deciding on causation. But it's in the world of artificial intelligence and advanced software engineering and so on and so forth. So it's not going to leak through into medicine for about a couple of centuries. All right, it just doesn't come through. But it's simply brilliant, the work. And what's really wonderful is he worked out a way of proving it mathematically. And in his book, he reproduces the proof that he did honestly on a paper napkin in a restaurant when discussing the matter with a colleague. It's just wonderful. And it's rather abstract maths, but it's there. He's proven causation. So we have a method for testing that. And if someone like microgen haven't done the work necessary to demonstrate causation, you can detect that because they will not claim to have shown causation.
Yeah. And
in fact, the thing to ask microgen is, what should my doctor do with these results? That's the knockout question, all right? Because, it's a question, I think we ask it that, are you telling me that we should treat the bugs you've isolated? No answer. Are you telling me that your genetic analysis of sensitivities we should be following? No answer. What is which of this group of microbes you've isolated is the cause of the infection? No answer. So really the problem with these tests, just like culture and with genetic testing, it's people are caught in the headlights. That everyone's been brought up with the view that you have to isolate the bug and you have to treat on that. That anybody who says, right, we've isolated a bug, people are just compelled to follow that. It's a compulsion. It's a sort of we've been trained into it, so it's almost an intuitive response to it. But we're maintaining quite, and we'll have, this is all based on the modern Judea Pearl work. We haven't cracked causation yet. We're absolutely emphatic about that. We haven't cracked causation. So if you grow an E. coli from your urine, in my opinion, it is more likely that E. coli is just thriving on the debris at the base of your bladder and is not doing you any harm at all, than that it's the cause of your disease. So why are you trying to kill it off?
Mm.
And so the difficulty with these tests is they always encourage people to use much more powerful antibiotics than is necessary. And it comes up the other day, I think I can't remember what it is. We are made up of 20 trillion cells and 29 trillion microbes. Right? So there are loads of bacteria there that are our friends. We've evolved with them. They live in a mutualist relationship with us.
Mm.
And if you come along with some powerful antibiotic because the culture or the genetic test suggests that you should be following that, then you're going to damage some of these, and it's terribly unfair on them. Terribly unfair. So I'm very against their use. And on top of that, you're being charged
Yes.
for them, and that's not fair. So I'm quite happy for people to start promoting them if they can demonstrate causation, and if they can't, then they're not there for clinical use.
How would you respond to doctors? So, for example, I had an experience with a doctor recently who said the only reason that I was feeling any better, having been on limecycline for a long time, was because it was one of the most powerful antibiotics in terms of its anti-inflammatory.
No, but this is another meme that's got loose in the community. Limecycline and azithromycin do have low-grade anti-inflammatory properties, but those properties are very slow in onset, and they're not very marked.
Mm.
We can see them in a laboratory model, but you can't see them really in the human organism. And on top of that, where we've compared them with the non-steroidal anti-inflammatory, right, there's absolutely no comparison whatsoever, none at all. That non-steroidal anti-inflammatories have a very limited effect in this disease, very limited effect. And the limecycline and the macrolides, the tetracycline macrolides have a much more powerful influence on the disease.
Mm.
And the other thing is that we understand the antimicrobial action, but to say that they're the most powerful anti-inflammatory drugs around is simply nonsense. If they were, they will be associated with appallingly troublesome side effects.
Yeah.
So if you think about, if you take indomethacin or naproxen or any of these more powerful anti-inflammatory agents and think about the side effects that they induce, okay, then you're not in any competition. But it was promoted quite a bit in the time of the antimicrobial resistance concerns, in order to provide a sort of ad hoc defense of why you shouldn't be prescribing antibiotics. But frankly, that the clinical evidence for them having that effect is zero.
Thank you, Professor. And
so the answer to that sort of thing is always the same. Oh, really? Can you provide me with the written evidence that that be the case?
we also had a lot of questions about Hiprex itself, because Joanne will come on to talk about the troublesome patients who can't really tolerate the oral antibiotics and how to deal with them. But we did have some questions about Hiprex and whether it is safe to use long term. So, for example, risks of developing kidney stones, any links to developing bladder cancer down the line. So is Hiprex something that's safe to take long term?
Right, so let's deal with stones first. Hiprex is an acid, so it acidifies the urine. And one of the treatments for renal stone disease is acidifying the urine. So when we start off, Hiprex should be reasonably friendly to that situation. However, there are circumstances where it may promote crystallization, and that's in people who've got gout, and in people who are taking sulfonifieds. Now that's the latter one's quite interesting because, as you know, we've been using trimethoprim more and more and more, particularly in combination with methenamine, or Hiprex. And recently there's been a supply problem with trimethoprim. So it's forced us back on to Septrin or Bactrim, which contains trimethoprim. And leaders say we forgot about the sulfonamide link. So we were woken up to it by the ever conscientious pharmacists. So we're having to tell people that while we're going to give you cotrimoxazole, which is Septrin or Bactrim, you'll have to suspend the Hiprex because there is a slight chance of crystallization and stone formation. Now, as to the cancer risk, this has got something to do with exposure to formaldehyde. But where we've seen bladder cancer associated with formaldehyde, it was in factory workers who were being exposed to really remarkable concentrations of formaldehyde for long periods of time. And they have those levels are nothing to do with the level of Hiprex. The manufacturers state that they've never seen a cancer link. And the other thing was that Hiprex was used for the first half of the 20th century on a huge scale to treat urine infection because it was all we had, and cancer was not identified. And we've not seen any instance of it. So my reading of all of it is that it is safe. It is safe. And I've got those two caveats about stones. I see one woman that really perplexed me, but every time we put her on Hiprex, the gout in her joints blew up.
Right.
I remember telling her, I can't understand this because it's meant to be blowing up in your urinary tract, not in your bloody joints, all right? But she said, well, it's happening. I said, I know it's happening. I can see it's happening. We can't use Hiprex. But everyone, people are different. Now, have I dealt with that question about cancer risk and so on?
Yes, definitely, and clearly, and very clearly.
Now, the very interesting thing you've got to learn is the phenomena of memes, which were invented by Richard Dawkins again. You can see that I'm quite a fan of his writing. But the memes get onto social media and they buzz around like no one's business. So the cancer risk for Hiprex can blow up just like that, get all around. Very difficult to put it out.
Azo dyes, so taking AZO as a way of tackling.
Yeah, well, the azos are really interesting because they date from the work of Ehrlich, who worked with stains, and Ehrlich stains, and I think Ehrlich's reagents may well have been used to develop the Gram stain. But he made the thought, well, hang on, if I've got these stains that are being taken up by bacteria selectively to share them out, perhaps I can use them to poison the bacteria. Which is quite a good idea, really. You think, God, there's a gram positive, no, there's a gram negative, no, gram positive bug, shut up, get it right in a minute. Perhaps it's going to die from its stain. And so he started working, and so did others, with all these different stains of one kind and another. Azo dies eventually. And they were trying to treat urine infection. And out of it came what's called azo, which I think is called Feni something or other. I've forgotten its correct name. But the other thing was that we discovered, that workers in the azo dye industry experienced bladder cancer. They had a higher incidence of bladder cancer in the days before you used industrial protection. So there's certainly a risk with exposure. But frankly, the risk of exposure, given the way people are using azos, which is a bit like paracetamol for a headache, there's absolutely no risk whatsoever. And I think it's a really good drug. I mean, okay, your knickers go red, orange. What?
Bright orange, I think.
Bright orange, whatever it is, your loo goes bright, or everything goes bright orange, and fluoresces in the dark. But you feel wonderful with your bladder. But I don't think that there's any risk. I think it's a good drug. It's not curative. It's just aspirin for a headache.
Yeah, I find if I can just pop in,
Yeah.
I take that sometimes, Professor, but I find it really helps with burning symptoms, and that's it, nothing else.
Yes, that's what it does. It has a local anaesthetic effect.
Yeah, and it really does work for me. It's not often I need it, but it does work. So thank you for answering that question, Professor.
Hang on, I'm going to tell you what it's.
I've got the box downstairs. I should have brought it up.
Just trying to tell you what it contains. Oh, bugger, can't remember.
It's okay. I think
well, we used to prescribe it not as AZA, but we used to prescribe it for its proper name when I was a young phenoxyparidine.
Yeah.
Phenoxyparidine hydrochloride. We used to dish it out like there was no tomorrow when I was a young doctor.
Okay.
There was a time when I was a young doctor.
Professor, just quickly while we're on the AZO question, because this is important to me as well, because I do use it when I need to.
Yeah.
What is a safe usage of AZO? So say for instance someone's in a weekly flow, would you say that it's safe to take every day?
Yeah, I think so. I mean, the point is that you need to be under treatment to get the flares down and so on. I think that the cancer risk is when you're being exposed to it all the time, every day, over a year or two. Just
use it as and when necessary.
Why do all of your patients not develop C. diff, Professor? Why are we all not suffering from C. diff by being on these long-term antibiotics?
Partly because I'm neurotic, all right. I can't actually. It was sitting that it's quite interesting because I'm sitting at the back. It goes out to our garden, and during the first years when we were developing the treatments in our other home before we moved here, in fact, I used to remember being out in the garden in the early hours of the morning, just sitting there worrying. I just couldn't sleep for fear of what was going to cause my patients and so on and so forth. And of course, C. diff was a big worry, huge worry, because if you get C. diff, you can feel absolutely terrible. So we got to set out with the view that we're not going to cause C. diff unless at all possible. So the first thing is to look after the good bugs in your colon. And once again, there's a garden example for that, because we got a few bird feeders out there because we're dead keen on flocks of birds coming to see us. And if you watch it, they go for different foods. All right. So if we put the mealworms out, we will very shortly be entertained by a lot of squabbling starlings. Okay. And the blackbirds are ground feeders, and they squabble. The goldfinches take off a feeder, and yet the chaffinches feed off the ground. So there's all this variation. So the secret in that is, if you want to have nice bugs around, feed them.
Yeah.
And the way of feeding them is to use resistant starch. Now, resistant starch is called resistant starch because it's incompletely digested. So some of it undigested goes through into the colon, and there it feeds the bugs that you want.
Yeah.
And this is just far better than putting in probiotics and all the other things. As far as I can make out, the only thing that probiotics does is sort of render you impoverished from the expense of buying them. All right, so you're a pauper, but you've still got diarrhea, which is a pretty rotten deal. Right. Since the resistant starch idea where I got is really good. Secondly, you've got to focus on using the antibiotics that have the lowest rate of C. diff. Now, the antibiotics that are most associated with C. diff infections are the cephalosporins. So why do we dish out cephalexin like we were stokers on the Titanic? Right. Well, the reason is that cephalexin is a first-generation cephalosporin. It is not a fourth, fifth, or sixth cephalosporin which cause the problems. And cephalexin has the lowest incidence of C. diff infections for the compared to all the other antibiotics. Now, we are heartbroken in our unit during this year to have to report 2 episodes of C. diff that occurred. It's so unfair that we inherited patients who'd been on the most horrifying cocktails of antibiotics under another unit, and we stopped them and correctly transferred to C. diff. And in both cases, that week they got transfer them to cephalexin, and in both cases that week they got C. diff. So we've had to attribute it to the cephalexin, but in fact it was due to the prior antibiotic cocktails. So in fact we've introduced a rule now in the unit that if they come in on these cocktails from another unit, they will go on to Hiprex on its own until everything's settled down and they've been eating resistant starch for a while. But you'll see that we focus on, if possible, a single agent, first generation, narrow spectrum. And nowadays, even when we're using combinations, we're sticking down at the bases. I mean, the most extravagant we get is with co-amoxiclav. And the other thing is that the email service is important. So people tell us they got diarrhea and instantly we say stop. Stop. All right. Yeah. We got but it's quite true. We got a very, very low rate.
A similar sort of concern that we see on the group along the same sort of lines in terms of side effects are the experiences with neuropathy. Now, what are the differences between true neuropathy and just symptoms which look like neuropathy?
True neuropathy is the loss of sensation. All right. The point about a neuropathy is that when you get a sensory neuropathy, okay, it's a loss of something. You lose sensation. Pins and needles is not a loss of sensation, it's increased sensation. That's the difference. Now, there are many, many causes for pins and needles of one kind and another. We think that the higher doses of the penicillins, cephalosporins, and so on and so forth can induce pins and needles because of ion pump effects on the nerve, sodium channel effects on the nerve. But I think that that's the main thing. The neuropathies we're worried about are associated with nitrofurantoin, and believe me, they lose sensation. All right, they don't have pins and needles. Now, the trouble is we don't help this situation, because if someone gets pins and needles, then we stop the antibiotic because we're neurotic about side effects. So they go away and you stopped my antibiotic because I have pins and needles. So immediately everyone's thinking, my God, I've got a neuropathy. Yeah. And in fact, we're quite used to this, you know, twice a year, there's a sort of neuropathy panic breaks out on the airways and I have to hose it down. But I'm still insistent on stopping the antibiotic if someone gets pins and needles, just because it's an effect that shouldn't be there. We don't think it's doing any damage at all, but I would never run someone while they're getting side effects. Right.
Yeah. So it's time to take a break at that point if they're starting to get those sorts of side effects.
Yeah, and usually all we got to do is reduce the dose or change the medication. And we're sticking to our 4 lovers down there at the bottom of the first generations, and it's going all right. So that I can assure you. I am conscious of the fact that well, it's my caution because I deal with the email service, so it's me that's stopping these things right, left. I know that I'm causing flaps out there, but I'm going to continue to be safe rather than sorry.
And I think that's probably what patients would appreciate, rather to be
but
safe.
I mean, they have to understand. I mean, many of my patients, I often say I'm ultra conservative in my practice. Yeah. Which means to say that it doesn't go as fast as some people would like, definitely.
Yeah, absolutely. Yeah, I mean, you could put people on broader spectrum antibiotics. They might respond more quickly, but then they suffer more.
I got that with the IV therapy. I mean, Jenny and I used to run this effectively as a ward in our research unit, and they come in and they get their IVs, and at the end of the week they were kissing us, and they were going to send us flowers and chocolates and so on and so forth. And he lasted a fortnight, and they were back saying, "What the hell's happened here?" All right, absolute dud thing, and that's the use of powerful antibiotics.
I've only got a few more questions in this section before I can turn over to Joanne. Just a few slightly more sort of random ones. People are worried about the long-term effects of taking antibiotics. So is there a danger in taking antibiotics indefinitely?
I thought that there's someone on Twitter the other day pitched me at a wonderful video about the foxes in what's it called, Yellowstone Park, and the effect of reintroducing foxes, not foxes, wolves into Yellowstone Park, wolves, and the remarkable effect it had on the ecology. What people have got to understand is that we're dealing with a biological system. It's Darwinian, and that it will self-correct when we remove the stimulus. They all do. So that you're seeing examples of some areas of rewilding. Now, I think some of the rewilding is simply batty that's going on, but some of the more sensible rewilding got a lot going on around us in Wiltshire, and it's being done really very sensibly. It's remarkable how the ecology comes back so quickly, so quickly. Now, a lot of alarmist stories are put out there because people are doing rather sort of, well, basically they're doing genetic work on feces and bowel and so on, and saying, oh, the microbiome's changed, and oh, it's changed in this way and that. Well, perhaps it has changed. If in the bladder you've got, in a normal person, you've got about 450 different species, and I perturb it slightly, shake it up a bit. If you look at it 5 years later, it's not a linear system. You're going to see different combinations. The idea that it's changing isn't, to me, necessarily a problem. Is it achieving any harm? And people can't answer to that, but I got great faith in all these ecological systems of resetting themselves. I think it's much more important that you've got a sensible diet, and you're eating a healthy lifestyle, and you're not drinking excess alcohol, and you're not smoking, and it'll all sort itself out. All right.
Couple more questions and then I'll hand over to Joanne. One of the questions we had was, how come some people have increased white blood cells in their urine but no symptoms, while others have or don't have that many white blood cells but they've got lots of symptoms? So how to count?
Well, I mean, the problem, there's a mistake that people are making there, is that they think that there is a direct relationship between the white cell link and the disease that they've got, the white cell leak and the disease that they've got. It doesn't make, evolution is extremely parsimonious. So if you're shedding a whole lot of white cells into the urine, that's an awful waste of good white cells. So it's not really in your interest to do it. So the body's going to be trying not to shed white cells into the urine as much as it possibly can. And so that the whole system is going to be buffered, so that you're never, ever going to be able to see a linear relationship between white cell shedding and the symptoms. It's never going to be. And there's no accounting for that. it doesn't mean to say that your condition is any less significant. So you can have a really nasty urine infection and nothing going on in the urine, and not to worry about it. If if you've got clear urine and we biopsy the bladder, we'll see a full-blown inflammation going on there. So and clearly you can see that with these oscillations that are going on, you've got to adopt a very, very loose relationship with that white cell count. I mean, that's why we emphasize the symptoms so much.
Yes.
So much. Now, in fact, the urine analysis, I thought that because of that, we were going to run the COVID thing really very, very straightforwardly, because we would rely so much on symptoms. But what I found was that we were running into difficulties because people were writing in and saying, my symptoms are simply desperate, I can't cope with this anymore, and so on. And we were shuffling the antibiotics. And then I discovered, when we started getting the microscopes onto them, that we were doing utterly the wrong thing. So really the importance of the white cell count in our unit at the moment is more to say, no, we're not going to change the prescription, this is working all right.
Okay, so it's more to monitor if that's falling.
So the young ones have contacted me several times today to discuss patients, and I know what they were feeling pressured because the patients were saying, "Oh, I'd know better, and the end of the world is at hand."
Yeah.
But their plots were quite clear, and I said, "No, you're going to stick at it, and we're going to give you some painkillers, but you're going to stick at it because this is working." Okay. All right. And it comes back to this thing that you've got this dead space. So the urine, the white cells come down and the urine clears, and then the symptoms persist. And then the symptoms, as we measure them, stop. And still we know that if we stop, they go and blow up.
Yeah.
So we're now going to run a study that's just about to begin slowly, where what we're going to do is get people to send in their stories, and we make it in a long story, and we're going to load it into the system, and then we're going to ask them to send in a story or a sort of an analysis of their state and what they think about the weather and whether they feel depressed by the Prime Minister and so on. That goes into the system, and then we're monitoring them as they go along. Now, at a later date, we will use artificial intelligence and text analysis to pull out words that are coming up reasonably frequently, or a bit. So I got an itchy nose. All right. So if I've got an itchy nose crops up 6 times, all right, then it'll go into a library of reference. So from the aggregate data, we'll construct a library of things that people mention. Right? Like, it may be that 8 times people have said, I'm depressed by the government. Yeah. Now we got the library. So then we go back and we start working with the individual. And if they come up with, if we extract a phrase or word that links into the library, then we give them a point. And that way we produce an extremely fine-grained individual scale that we can use once our crude scale has stopped working, and that we can base the response on the individual's personal experience, and that will guide us all the better as to how they're doing and when we should stop.
One last question, and then it's over to Joanne. In terms of, you get to the point where you think the infection has cleared from the urine and cleared from the bladder, and there's no urgency left, there's no leukocytes, etc., and we think it's safe to go off the antibiotics. Does bladder nerve pain ever persist? Are the bladder nerves ever just
the bladder nerve pain gradually peters out?
Right.
I got a very interesting patient who I've known for years, who's got this point neuropathic pain that's a bit like an appendicitis.
Right.
And she points at it each time. She's been gradually dying away over a long period of time. It goes eventually. You've just got to hang in there.
So the nerves will eventually heal, but it may be a slow process.
It'll be a slow process, yeah. Now, the reason it's a slow process is not because the nerves are taking time to heal. It's because the inflammation is taking time to heal. So you've got this inflammation going on and on and on, and you've just got to keep up this relentless attack on the cause of the inflammation.